Welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Hello, everyone. Welcome to the Surgical Assistant Podcast. As usual, I'm Kelly, and with me today is John. Hello, John.
Hey, Kelly, how are you?
I'm good. How are you doing?
I'm well, thank you very much.
Traveling the world still?
Yes.
Assignment to assignment, contract to contract.
Yep, that's me. I went from northern Michigan down to West Virginia, so I love it.
Nice. Good. Summer's going well. The year's flying by fast as usual, and we are just glad to be here. Still churning out these episodes a little bit slower than when we started off, but we are excited today to be recording the third of our hernia series, which we had planned to do. And we're approaching the hiatal paraesophageal hernia today. We're going to be talking about that and the ins and outs and what we need to know as surgical first assistants when we're doing these repairs. And John, one of my goals when I think about this podcast is for first assistants that maybe are just starting out or maybe have not been doing this for as long as you and I, and God knows we don't know it all either. But for them to say, oh, I'm going to be in this case tomorrow, let me run to this podcast and see if they've got an episode on it, and to click that button and listen to an episode and get some tips, get some information that maybe they don't know. And I mean, it's a little bit, maybe hopefully less boring than going to a book and finding it out, but God knows there's plenty of resources other than us. But this is hopefully going to be in a nutshell kind of informational pattern today. So we're talking about that hiatal and paraesophageal hernia. And I'm going to let you start us off, John, and we're going to just dive right in, start talking about the difference. I've always, a lot of the time, considered these synonymous, but they're not quite synonymous, are they?
No, not at all. And I just want to piggyback on what you said. That's kind of the reason that I was driving that day, heading to another assignment. And I called you and I said, hey, do you want to start a podcast? Because cases like this, when they come up that maybe I haven't done in a long time or have never done, I can go on YouTube and watch a video of the surgery, most likely. But I wanted it from the person. There was no resource for us as a surgical assistant to go to hear the caveats and the pearls, or like you like to say, the landmarks and landmines that'll put those things in the forefront of our mind that we need to be aware of.
And be thinking of and considering as the first assistant in the room. And that's
especially,
always the viewpoint.
Right. And especially for a case like this, because you're in tiger country. I mean, you're near what Maddox calls the surgical soul, but you're right above the aorta. So we're going to get into that. But so I was always confused by the difference between a hiatal hernia and a paraesophageal hernia. Kind of they're synonymous in the fact that there's 4 types of hernias for hiatal hernias, basically. And the type 1 is your true sliding hiatal hernia. But then anything the 2 through 4 are your actually paraesophageal hernias. So
the sliding, from what I understand, is the sliding is just refers to that lower esophageal sphincter, the LES, referred to as the LES, as we know from our anatomy, is typically sits down in the abdominal cavity as it goes into the stomach. And the sliding, that refers to it kind of moving up, being mobile, in other words, through that opening in the diaphragm, right? Exactly.
And it's typically diagnosed with a upper endoscopy. And those type 1 sliding hernias tend to be 90 to 95% of all of the hiatal hernias. It's the other ones that are obviously less common, but they're a lot more bigger of a deal. So your true paraesophageal hernias, though, only count for 5 to 10% of all hiatal hernias. But the type 2 is considered the classic paraesophageal hernia, and that's where the front of the stomach is above the GE junction, but the GE junction is still fixed in place. It's not moving. Okay. And then you have the type 3, which is called, kind of referred to as a mixed paraesophageal hernia, and that's both the fundus and the GE junction are displaced superiorly above the diaphragm, or the GE junction, above the diaphragm, so above the hiatus technically, because you have that embryologically, you have the hiatus when we're developing, where the aorta comes through. You have a little bit over, a little more laterally is where the IVC comes through. So it's that weakness in the abdominal wall. So it's big enough to let the aorta through and some of the other structures that need to come through. But like anything else, over time, they get worse. If you have a congenital defect, it can widen. Collagen disorder maybe, or women get it from pregnancy because the increased abdominal pressure. Overweight men get it
Mhm.
from being overweight and the constant bearing down. And then, so that was type 3, the mixed. And then you have the type 4, which is considered the giant hiatal hernia or the giant paraesophageal hernia because it contains structures other than the stomach. I've seen, I'm sure like you have, I've seen the entire stomach. I've seen the transverse colon, the omentum, the
It's
patient's left
shocking.
shoe in there. I mean, yeah,
It's
it's
shocking.
huge. It's
It's
huge.
shocking to see the contents that they can pull out of those things, and I'll be
Yes.
very transparent, I have not done a whole lot of these surgeries, and probably that type 4, I probably have only seen 1 or 2, I would say.
Yes.
Less than 1 hand. I mean, very, very few of those, but you don't
Hmm.
forget them because
No, that's
of
true. Yep.
the contents that they pull out of the chest cavity it's shocking, like I said.
Oh,
So,
yeah. And those
it
type
and
4s, they're usually associated with large diaphragmatic defects as well. And you'll probably only see those at bigger institutions, tertiary referral centers, or maybe bigger community hospitals that are level 2 trauma centers, something where they have more robust services they can offer that. You're not going to get that at your rural 5 operating room hospital. They just won't
Mhm,
operate on a patient like that because
mhm.
they don't have the services. I mean, I don't want to speak for every hospital, but they don't have the services to support those
Support and
patients.
whatnot,
Right.
right.
So,
Right.
but yeah, so
So
those are the types of hernias, and the repairs basically fall into 2 different categories, and that's laparoscopic, the way I've seen them done, the laparoscopic or the robotic for what we're speaking. I mean, we're not talking about an anti-reflux procedure, which was a surgery called the Belsey Mark IV, and those were typically done by chest surgeons because you go in through the left
mm,
chest. Very morbid incision because if you get a leak there, it's a big deal. But it's not done so much anymore now with the advent of these MIS techniques, and that's
mhm,
the brilliance of laparoscopic, which is now evolved into robotic. I mean, you have wristed instruments that make it so much easier. I'm not going to get into. I know you're going to talk more about the robotic. I'm not getting into your wheelhouse, but it's just it's safer now to do it. And you can offer this operation to maybe patients who are asymptomatic that, hey, listen, it gets worse at a rate of 1% per year. You're healthy now. Let's take care of it and you can fix it. So, but yeah. And as far as the anatomy, I mean, it's pretty basic. What the stuff we're worried about, though, the stuff you definitely need to be aware of is the aorta is going to be right there, posterior to your repair. You have the IVC just over to the left, your left side, patient's right side, near under the liver. The celiac trunk is there. There's a ton of
mhm.
arteries. You have the short gastrix. And that's the caveat to these operations are I've seen a lot of surgeons, they don't want to immediately go and reduce the hernia. They don't want to start pulling the contents into the abdomen because if it's been there for a while, chances are it's fixed in that position and you'll just tear things. You can tear the short gastrix and get into bleeding you don't
A
want to
great
get
point.
into.
Yeah.
So
Mhm,
the idea and what I've seen done and what I've done reading on this is to reduce the hernia sac first. So take the hernia sac down and the stuff will naturally come with it as you take the hernia sac down. So
mhm.
into the steps of the procedure later, but
Yeah.
and it's basically pretty simple. I think it has like 5 or 6 steps. It's a pretty simple, but not easy.
Not easy. Straightforward. Yeah, there's the
Yeah,
steps are
it's pretty
straightforward.
straightforward,
So,
but as long as you're prepared, because if you have the equipment ahead of time, because there's really specialized equipment that you need for this. Patient positioning is kind of straightforward. Kind of falls into one of 2 categories. So is that
what about the fundoplication part, John? Now, is there ever just a direct repair with maybe, I know there is mesh. We talked about there
mhm,
are mesh repairs that they will overlay mesh over the repair. I have personally never done one of these, I don't think, that have utilized mesh, but that is a possibility. So we want
mhm,
you to consider that as the first assistant. Does your surgeon, is he planning, are they planning to use mesh? We know they're going to close the defect with suture. They're going to
mhm,
close that and tight, proximate the edges of the crura to where they're
mhm,
fitting now more neatly around the esophagus after everything's down. But the fundoplication part, can we talk about that? The Nissen versus the toupee.
mhm.
And is that, from your understanding, is the fundoplication done only in the type 2 or more severe, the paraesophageals, I should say?
I would say it's a comp out, but it's patient dependent. I mean, you can
Okay.
have a type 1 that's a simple fix with a couple of stitches, but then the patient has really bad gastroesophageal reflux disease. So
Mm-hmm.
you're there and you have to take down some of the same structures. So the surgeon
Mm-hmm.
might just go ahead and do either a Nissen fundoplication or
Mm-hmm.
a toupee fundoplication. So for
Okay.
people out there that don't know, the Nissen fundoplication is
Mm-hmm.
where you take the stomach and you wrap it around the fundus of the stomach, you wrap it around at 360 degrees around the stomach whereas a toupee is 270 degrees. So it's not completely all the way around. And Dr. Nissen, just as a little historical note, came up with that procedure just on the fly because he had a patient come in that had an esophageal ulcer that eroded into the pericardium. So he brought the patient down. He didn't know what to do, so that's what he did. He wanted to cover the defect, so he wrapped the stomach around the esophagus after he closed it, and the patient reported that his gastroesophageal reflux disease went away. So he started offering it to more people, and they started saying the same thing, and then that's kind of how it happened. A case of one, basically. Let's just do it. You couldn't do that today. You couldn't just say, hey, we're just going to go in and take this out and see what happens. But that's what he did.
We don't have enough studies on that. But
but here's a little historical footnote, too, is that Dr. Nissen was the surgeon for Albert Einstein. So he did his aortic abdominal aneurysm. I wouldn't say I wouldn't say it's a repair. Back then, they really didn't know what to do, so he opened them up and put cellophane over the aortic aneurysm and closed them back up again. That created scar tissue. But as we know, Einstein later died from a ruptured AAA. But everybody's seen that famous picture where he sticks his tongue out. He's got a stunned. He actually sent that picture to Dr. Nissen, and the caption said, "My tummy belongs to Dr. Nissen. For the rest of the world, my tongue." That was what he wrote under that picture when he sent it out. So it's a little historical footnote about that.
I love that. Yeah, okay, so I just wanted to differentiate that. So talking about those fundoplications, and so that as the first assistant, is it with a toupee, is it with a Nissen, and that's just referring to how much of the how circumferential the wrap is of using the fundus of the stomach, and
exactly
we do that because, as John just explained, that reduces their GERD.
Right, and it also prevents the the stomach from going back up into the chest
mechanically. Exactly,
right, mechanically it does that. And a lot of docs will hang that repair on them, but we'll get into that. But that's a good point, and this is a good thing you need to differentiate. And this is what a good first assistant will do, because depending on how well the case is written up or booked, you may just see hiatal hernia repair on the schedule.
That's true.
It could be a type 4, which is going to be a much bigger procedure with a lot more equipment and suture and things you want to be ready for than a simple 2-centimeter hiatal hernia. So that's where it comes in, where you read the H&P. If you have access to Epic, maybe read only or whatever, you want to go in, you want to look at the patient's H&P and read, and in there will be a diagnosis of a type 3 paraesophageal hernia or a type 1.
And you'll know when you read that in the H&P. So that's, John, that's always my go-to, is to really get in that patient's history, get in their chart as much as I can. And whenever I can, that's what I want to do. I want to read what the surgeon wrote in their H&P. I do want to emphasize again to our listeners, elevate yourself depending on the relationship you have with your surgeon. Go to your surgeon and say, hey, maybe you weren't able to see the chart. Maybe you weren't able to see the H&P, or the information wasn't in there. Do not be afraid to approach your surgeon. Guys, read the room. Okay. We want to read the room. We want to know there are a lot of different circumstances, but depending on your relationship with your surgeon, how long you've been working with them, et cetera, I would say even on a travel assignment and you've never seen this surgeon before, it is fine to go introduce yourself and say, hey, do I need to know anything more specific? This case is booked as a hiatal hernia. Is it any more complicated than that? Anything you want to let me know? Are we looking at a paraesophageal? What degree is know these questions to ask. Your surgeon is going to it's going to increase their confidence in your knowledge when you know about these details that John has discussed about the history of these, the types of the paraesophageals. That matters because you can then go to your surgeon and say, we all know that they don't get booked appropriately a lot of the time. And that's where your professional knowledge comes in, and you're going to know what to anticipate for the case. So I just really wanted to interject that here. Don't be afraid. But again, it's always my go-to. I'm always trying to respect the surgeon's time before the case, and I want to read it for myself in the H&P. You can extrapolate a lot of valuable information from a good H&P. And in a case like this, I've found that they really do kind of give you a good solid history in that H&P.
Yes, but I think you brought up an excellent point. And yes, you want to respect the surgeon's time, but I'll tell you what he'll respect a hell of a lot more is being prepared rather than he gets into trouble and I need such and such, and the nurse has to go find it.
I didn't want to bother you is not going to be the answer then. No,
but I'll tell you what, if you're new, if you're a traveler or whatever, I'm telling you, nothing will engender trust more than you talking to the surgeon like a professional.
That's right.
Saying, how big is this hernia? And he says, oh, well, blah, blah, blah. Oh, it's a type 3 hernia. if a
Just
surgeon knows
basics,
you're
y'all. I mean,
engaged, you
yep.
know the criteria for you know the procedure, it's more confidence that they have in you that will go a long way to building trust with the surgeon.
Yeah,
Because
they know you.
those of us out there that travel, it takes time. And you can lose
Mhm.
it in a second. It can take a whole
Mhm.
entire assignment to build trust, and you can lose it in one case
Mhm.
if you listen to you go against your own intuition and listen to somebody else instead of whatever. But this isn't the place for that. But definitely, you want to be prepared because then that case goes much smoother for everybody involved, but most importantly, the patient.
Well, John, I know you were just you and I both can get
Mhm.
off on a tangent. And we
Right, right.
do
Yeah,
we
yeah.
all to the listener, we really are trying to do better with that and keep these pertinent and relevant and get away from that. But again, I
Mhm.
think this is vital information for that first assistant because how many times,
Definitely.
and I've got to say this, have you and I as travelers, I've traveled, you're currently traveling, I've started a new job in almost 13 years of doing this. I've been in a lot of places. How many times have I had that seasoned circulator in the room
Mhm.
say, he never uses this. He'll
No, yeah.
never do that.
Mhm.
She never does this. And what I want to say to you listening right now is take responsibility for what you need to know as the first
Mhm.
assistant. I love teamwork. I really appreciate the team that I'm working with, and I love corroboration and collaborating with my team in the room. But you have got to know as the first assistant things by virtue of being a first assistant and how
Mhm.
we were trained and how we were educated, things that the circulator and the scrub tech are not going to be thinking about. That does not make you arrogant. That does not make you feeling like you're above everybody else. It just means that things from a
Mhm.
perspective that they just simply don't know. It's not how they're trained necessarily. So
Right.
please follow your gut, be that professional, like John just said.
Mhm.
Approach your surgeon if you have any questions, because in that case, during that case, you want to have what you need in that room. You don't want and at the end of the day, you saved everybody. You've saved the
Mhm.
CST from not having what they need. You've saved the circulator from running in and out, getting things. Just that's really sage, good advice that I'm giving you
Mhm.
that I've learned from experience and that people told me and taught me as well, and I've learned it for myself firsthand. So I had to
Exactly.
interject that.
That's no, that's
And I know
perfect.
that's exactly what you were saying,
Yep.
John, and we don't want to get off on a tangent talking
Nope.
about this place we were and this place we were. We're not going to
No.
do that.
But everybody has their own responsibilities. The nurse is worried about the patient, the counts, the
Correct.
medication, allergies. The
Mhm.
tech is worried about, do I have this? Do I have that? Is this ready?
Mhm.
Is that ready? So everybody has their own responsibilities. Our
Mhm.
responsibility kind of covers all of that stuff, but it also, if we know that he's going to do, it may not be booked that way as having a fund application in it, but we know that
Or
surgery entails it. So you're going to
mhm.
have those things that you
Yeah.
need for
Let's be
that.
prepared. Let's
Right.
have it in the room. Let's
Or you
hold
don't
it.
have to,
Let's have it
right.
available.
Right,
Right.
you have it available.
Things,
You don't have to open it. If you're
whatever
getting
it
pushed
is.
back, "Oh, he never
Mhm.
uses that," say, "Well, you know what? It's right here in case he does."
Right.
Then she'll respect you for that because she's not gonna have to go darting outside of the room to try and find something.
Mhm.
And, "Well, I'll take this. Oh, it's not open, but it's right here." Surgeon's not
Mhm.
gonna get pissed about that, but
That's
he
right.
will get pissed if you have to go find it
That's
and it's not
right.
there. So, yeah. So, basically, yeah, so that's the types of hernias, and they I don't know where you wanna go from there.
Like,
Basically,
yeah,
break
John.
down into
Well,
2 types of repairs, basically, either
yeah.
laparoscopic or robotic.
Right.
So
And John, just to recap what John said about our anatomy that we're
yes, thank you.
encountering, he named a lot of those important structures. I did want to point out for sure the pleura. I want to highlight that the
Oh,
right and
yeah.
left pleura,
Mhm,
they're going to be working very close to that. So along those lines, you want to be thinking as the first assistant, if they get into the pleural space, we're going to need additional supplies then after the case, maybe a
chest
drain,
catheter, yep.
chest catheter, drain, the Pluravac, Plurex, whatever your facility has. And it's another question you can ask if you don't know. You can ask the surgeon, what are if it's not pulled for the case, for instance, that will show, especially if it's not pulled for the case, that will show your surgeon, oh, wait, they know this is one of the landmines to watch out for. And they don't want to
Yep,
get into that pleural space, but sometimes they
right.
do. It happens.
It's
And we
just
want to be
yeah,
prepared for if we do. We don't want to be looking all over the hospital for
mhm,
because not all ORs just have them handy in the main OR.
right.
Ask me how I
Maybe
know.
an
Uh-huh.
interventional radiology and you have to send over for it, but at least get
Correct.
it and have it in the room. I'm always of the mind that I'd rather have it and not need it. So, no
Right.
matter what they say, I'm still gonna get it and have it in the room.
So
because
not
I'll
to
bring
jump
it back
ahead
over
because
when
we
we're
are,
done.
yeah, exactly. And we are going
Hmm.
to go over supplies and
Hmm.
instruments extra that you may need for these. And I did kind of get ahead of myself there, but that was in that anatomy coverage of things that we're going to be working near and around. You want to know you always want to know your anatomical structures that you're going to be working or that surgeon's going to be working around.
Hmm.
So that was just something I did want to pull out there. But yeah, let's move on to the different approaches. And we know both of these are technically laparoscopic. One of
Hmm.
them is going to be assisted by the robot. It's going to give us some more considerations, but you're going to talk about that laparoscopic approach first, and we're going to start from the ABCs of all that we need to know.
Sure, thanks, Kelly. Yeah, the and that's all surgeon preference. I mean,
Mhm.
obviously, we can see the usefulness and how well the robot does with these cases, and it just from the steadiness of the camera. I mean, some surgeons like prefer to work with other people as opposed to others because they hold the camera better or they anticipate better or whatever. So, but that's in all how they're trained and how they feel comfortable with it. So, and that's what a lot of this will boil down to is how they're trained, whether they do a toupee or a Nissen. A lot of that has to do with the patient as well, but it's also in how they're trained and what they're comfortable with because there is a steep learning curve to this. But the steps are pretty much the same. It's just how you achieve those steps is depending on what platform you're using. So I did a lot of these laparoscopically because I'm older. So I've been doing it a little bit longer. So I tend to do, came through the laparoscopic era. So a lot was done laparoscopically. Now we're doing them robotically. So, but, typically when you do them laparoscopically, you're going to insufflate the abdomen. You're going to need a liver retractor of some sort. And we'll get into some caveats later or some tips and tricks later where we can tell you all the different types of, or ways you can retract the liver out of the way. But typically they'll use a Nathanson retractor, which is used in bariatric surgery a lot because you have to get really high up into the hiatus when you're doing those. You got to get to the fundus of the stomach. But anyway, so typically you'll use a mixture of ports, 5 millimeter ports. You might not even use a port for the Nathanson. They just might put that through the skin, make an incision, and then put the Nathanson in that way, hook it up to the bed, retract the liver out of the way.
In
You'll
our
need it.
position, John, just to interrupt you
Mhm.
for a second, our
Oh, I'm sorry.
position,
Thank you.
some
I
of
should
the
start with that.
bearing
Yes.
of what kind of liver retractor we're using, how are we retracting the liver, may have some bearing on our position, at least of the
Hmm.
arms for sure. So
That's a
let's
good
talk
point.
about, yeah,
Thank
about
you.
that positioning, the
Yes.
typical positioning for these.
I appreciate that because I did get off on a tangent,
Hmm.
jumped right into it. But right, you're talking about patient positioning now. So the patient's going to typically be supine in a steep reverse Trendelenburg position, anywhere from 20 to 30 degrees. So that means you're going to want to have a footboard on the bed and you're going to have whatever kind of anti slip system you guys have, whether
Mm.
it's the pink pad system or the tracks or whatever. I've seen some great ones over the years. So you're going to want to use that. Whether or not you're going to tuck an arm or not is surgeon preference. And then, like Kelly said, that depends on how he's going to use a liver retractor. If he's going to use a Nathanson or the Diamond Flex or Laparaflex, whatever particular name brand it is, that usually attaches to the bed via clamp. So you're going to need to have room for that. You don't want the patient's arm tucked by their side because that's going to interfere with that retractor. So that helps to know which one your surgeon uses for that. And then you'll see if there isn't one on there, then you're going to want to go ask him. But typically, their laparoscopically is done either two ways, supine or what's called in a split leg or French position, where it's a special type of bed where the legs actually split apart and the surgeon stands between the legs. I've done that a few times, not for hiatal hernia repairs, but some bariatric surgeons do it. And I did that when I was working in Michigan. So one of the bariatric surgeons there did it that way. It was the only time I've ever done it in that split leg. But it's very nice because you're not really playing surgical twister trying to get you really stretched out getting your visualization. So a lot of times surgeons will use a bigger scope for this. They'll go ahead and use the 10 millimeter scope because they want a better view laparoscopically. So they'll use a 30-degree 10 millimeter scope typically, and it's going to be typically off to the side, usually in the left paramedian space or the right paramedian space where they want to see it. And it's going to be up higher. It's going to be higher than the umbilicus because they want to be able to look up into the chest rather than trying to look over the stomach into the chest. And then there'll be a mix of 5 and 10, maybe a 12 trocar, depending on the surgeon's preference and how he does the operation. But
Hmm.
so for this laparoscopic procedure, you're going to want to have the energy device that he likes. Typically, a lot of times surgeons will use the harmonic for this. Some will use the ligature, but a lot of docs like the harmonic for a certain reason. So, and when you start with the procedure, you're going to want to start with a lot of docs will start in the pars flaccida. That's that thin membrane in the lesser curvature of the stomach.
Hmm.
But more and more surgeons now are starting more towards 12 or 1 o'clock because there's a lot of reasons you don't want to get into the pleura. The IVC is off to the left there on the left cruce, but a lot of doctors will start at the bottom of the left cruce to start to dissect out the hernia sac. But it's actually easier, from what I've been told, to get into the hernia sac if you start at a little off, like 1 or 2 o'clock on the hiatus there itself. And then you start dissecting out the hernia sac. You want to clear the pleura. Sorry. You want to clear the crura of the overlying peritoneum. It's a tongue twister.
Hard words.
Yeah.
To say.
Right, exactly. So they'll strip the peritoneum off and get down to the bare muscle fibers of the crura, and you have the right and left cruce, which is where the hiatus is. So usually, typically, they're, depending on how big your hernia is, they can be really intensely dilated, and you have to, eventually you'll sew them together to close down the hiatus. But you'll need whatever type of energy device they want for that. You're going to need different types of graspers, whatever they prefer, whether it's surgeon preference. So just read the card. And what you're going to have to do is you're going to have to dissect high into the chest, almost to the reflection of the pericardium or even the carina. Some docs will go as high as the carina in the chest, because you have to dissect off all the attachments to the esophagus. Mm-hmm. And you want to make sure you have at least 3 centimeters of the esophagus in the abdomen. So that may require you going high up into the chest to release that. Very mindful of the anterior and posterior vagus nerves. You want to be very mindful of the vasculature, because the aorta is going to be right there below the esophagus, because as we know, the aorta sits on top of the esophagus. And there's perforators that come up anteriorly from the aorta. So a lot of docs, you know how they'll separate tissue when they do their dissection, like they're swimming this way in a breaststroke, but they want to for this, they'll do it more anterior posterior, because they want to go along with the perforator so they can take them with the energy device. And they'll first thing they'll do is strip off the hernia sac so they can reduce the hernia, and they may have to bivalve it, so cut it right up the center. But they'll dissect the hernia sac out. Once the hernia sac is out, they'll tug on it to make sure they have enough of the esophagus down into the abdomen, and then they'll start closing their crura in whatever way they've been taught to do it. Doctors will do it with interrupted 2O ethibonds or 0 ethibonds on an SH and a laparoscopic needle holder. Some doctors will do it with the endostitch and a 2O Surgideck or a 2O ethibond. And this is where it behooves you to know your instrumentation. That endostitch is so effing finicky. If you have a tech that does not know how to do it, and I was at a place where the tech did not know how to do it, said she knew how to do it, but didn't, we went through an entire box of suture. And now the new sutures for that come in a pack where there's 3 needles in each one. And I forget how many, I think there's 5 in a box. We went through an entire box. So that's 15 needles we went through that she bent because she did not properly know how to do that. So if you don't know how to do it, there's plenty of great videos on YouTube. Go on. It literally takes 10 minutes before the case.
Great idea. It's a great
simple
tip.
to review. You want to know that, because it's a finicky device. And the surgeon, after the 3rd bent needle, she looks at me. She said, "Do you know how to use that?" I was like, "Yes, ma'am." And I showed the tech, "Hey, listen, this is how you do this. This is do this, boom, boom, boom. Perfect." It was after that. It was great. So they'll use either that or an endostitch or a free needle with endoscopic. And then that's where, as you as an assistant, will come in, because you'll have a pair of scissors, laparoscopic scissors. And then when the surgeon is done tying it, that's another great thing about the endostitch is you can just switch the needle back and forth and make your knots right intracorporally. You don't have to pull it out and use a knot pusher. Although some doctors, I worked with a doctor that still does that. Or if they're out of endostitches for whatever reason, they're going to have to do it that way. And I've had that happen before. So keep that in mind. But then you can have the scissors ready, and then you can stage it as you count how many knots they like to put in. I work with surgeons that like to put 6, 10, 12, whatever. So keep a count on where you are so you can stage it, bring your scissors in so that when they're done, they're ready for you to cut. And a lot of times they'll leave the tails just laying there. But if they're doing something, preparing the needle for the next one, I'll go in with a grasper, pull the stitch out, the remnant, whatever's there, because it saves time to do that. So rather than pulling them all out at the end and chasing for them. So after they do that, they'll close the crura. Some do it in an interrupted fashion all the way up. They'll put a bougie down the esophagus. They'll have anesthesia put a bougie down into the stomach, and that's whatever way they're trained, however they like to do it. Some people don't use a bougie. Some people I've seen use a 36, 53, 56, whatever they're trained in how they do it, but have the bougies available. I think the Savory McGills are the bougies that they like for that. Anesthesia will typically put that down or if they have a single bougie that they like, make sure you have it ready to go so the anesthesia can deliver it. After they put the bougie down, they'll close up the crura all the way up to the top. Some will put a stitch above the esophagus, and then the rest of the stitches below the esophagus all the way up. The key here is you got to be very, very careful when they always usually typically start from the bottom up, or when they go to the bottom up. You got to remember that aorta is right there. So a lot of docs will push it down with their other hand, or they will have you do it. You push down the aorta while they put their stitch through because they don't want to catch the aorta.
I definitely like to have a padded grasper on these.
Yes. Oh,
if I'm the assistant, the padded grasper.
Yes. Yep. The applied graspers that have little bumpers at the end. Yeah, that's a great one for this too. And if you see that, you'll see them pass the stitch. And then if you see blood welling up, you want to call that out because you don't want to tie it down on, leave it in because they will develop a fistula later on. So the surgeon will pull that suture out, which may cause even more bleeding, but then you can deal with that. And there's ways to deal with that, but keep on an eye out for that. Be very careful when they're putting those initial stitches in that the aorta is out of the way. You're keeping an eye on the aorta. You can say it, okay, I see the aorta, it's out of the way. Communicate with your surgeon. It's very vital during this phase. Some will use mesh, some won't use mesh. I've seen docs cut the phasix mesh in like sort of a C, and they'll put it from the bottom up and attach it. Some include it into their stitches around the crura. Some lay it over the crura after they've closed it and then stitch it in place. Some doctors will cut pledgets from Vicromesh and use that. One doc I worked with used interrupted silks and ethibonds, and they would put in a single interrupted silk, then an ethibond in a horizontal mattress fashion, then another single, then a horizontal mattress, single, all the way up until it's closed. You don't want to close it super tight because the two worst complications with this procedure are dysphagia and gas bloat. That patient will hate you for the rest of their life because they'll constantly be in pain from gas, or they'll get bloated because they can't pass the gas, or they can't swallow. So that's why they don't make it too tight. They want to that's why they typically use a bougie. I haven't seen too many doctors not use a bougie. Well, they will either onlay their mesh as they're closing or after they close it. And then once that's closed and they're happy with it, then they'll turn their attention towards the fundoplication. And then it depends on which one they're going to do, but they'll take down the short gastric arteries. You want to be careful when you're near that fundus pulling on that stomach, because remember, the short gastrics have it if it's not too displaced, depending on the size of the hernia, that's attached to your spleen. So you'll be near the spleen. You want to be careful of that. But then after they've freed the stomach, that's another thing you're going to need a Penrose drain, because you're going to have to retract the stomach, and depending on when the surgeon wants to put that in. Now you can use it. I've seen it done many different ways. You cut the Penrose ahead of time, you pass it in, they pass it around the esophagus, and then they could either clip it with a hemalock, they can clip it with a hemoclip. I've seen them suture it with a stitch, or you can actually make a vertical slit in it. You can pull it. You've seen that, right? And where they pull it through it, now it's kind of like a lasso around the esophagus, and that's where you'll grab and manipulate. The surgeon will tell you how to do it. And then what they'll do is they'll have you hold that up. They'll pass a grasper behind it. I mean, they have disposable graspers that are articulating that you can use this with, or you can just use another grasper, but they'll pass the stomach back around to themselves. They'll make sure it completely comes around, and then they'll do what's called the shoe shine technique, where they'll windshield wiper it back and forth to make sure that it's free and it gets all the way around, whether it's 270 or 360. And then they'll start suturing that. They'll grab a piece of the fundus, a piece of the stomach body, or a piece of the esophagus, and then a piece of the other side, and tie it down. And they'll do that. Some will hang their repair on the cruce after they're done. Some won't. Just depends on personal technique. So after that, you'll take the Penrose off, and you're pretty much done. You want to take the liver retractor out, things like that. Some guys will use TIS seal afterwards. Some don't. It's all surgeon preference. I'm trying to think if I left anything out of that. Once the fundoplication is done, a lot of docs will leave the field and go up and do an EGD right away, because they want to make sure that they've restored that Z line, or whatever, that little circular Schlenker's line. There's a name for it. I can't know what it's off the top of my head, but that they want to make sure that they've actually reconstructed the gastroesophageal sphincter. I mean, a sphincter is a circular muscle, and there technically isn't a circular muscle there, but it's been called a sphincter. So some people call it a low pressure zone, or for the lower esophageal sphincter. So it's
by doing that endoscopy at the end of the case, they can kind of see their work. They can kind of see what the result is from the inside, which is important.
Right. And they want to make sure when they do the fundoplication, they don't back wall the esophagus either, or their stitches come through. That's the wonderful part about the endo stitch, is it was designed for suturing the esophagus. So if you clip it, if you grasp it in the correct way, it won't go through the mucosa. It'll just go through the serosa. It's wonderful. It's a wonderful instrument. It was,
Yes, it is.
if I remember, it was invented at George Washington University for that exact reason, to not go through the mucosa. But yeah, so after that fundoplication is done, then pretty much after they'll do the EGD, and then you're pretty much done. Then it's closing your ports in whatever fashion. The bigger ones you'll
Mhm.
close with an M close or a pig sticker or a fascial closure device, whatever you guys call it, or Carter Thompson, however
Mhm.
the surgeon does that. Typically, I haven't seen them put any drains in. So now depends on if they've gotten into the pleura, because you have to dissect the pleura away when you're going up into the chest, into the mediastinum, take down all the adhesions and push the pleura away. You can get into it because you're talking a couple of cell layers difference. It's not
Mhm.
much. It's easy to get into there.
Mhm.
If it's a pneumothorax, that's a big deal, but a tension pneumo is what you don't want. And a tension pneumo is where air goes in but doesn't come out again. So the more air goes in, the less the lung can expand, the more it compresses, and it's actually can be fatal. So that's what everybody dies from, is a tension pneumo when they have a pneumo. So the key to that is just make your hole bigger. And you can put a red rubber in there if you don't have a catheter, and you can suck out the CO2 at the end, and then it'll naturally seal itself. But the idea is anesthesia will catch that because they'll see a huge spike in the
Yeah,
CO2. So be
right.
aware of that. And that's anything I have. Can you think of anything I missed?
Yeah, I have a question. How often do you think, I don't think I've seen this very often at all, if ever, do they amputate the hernia sac? Do they just leave it in, or are we looking at a specimen coming out?
No,
Like, at
pretty
what
much. I've
point,
always seen them take it out if they're able to,
they,
unless they're going to get into too much into tiger country posteriorly to take it off. But if
I
not, they
see.
will bivalve it, and you'll get majority of it or pieces of it. But they will take it out. From my
Okay.
experience, they do take it out.
Okay. So
Now,
in that case, you do need a
you brought
bag.
up
They bag it.
another thing I wanted to bring up. Now, depending on how big the hernia is, you want to be able to, when you close this, you want to make sure you don't have too much tension axially or horizontally. So a lot of times, oh yeah, I forgot another thing I wanted to bring up. If you can't bring down 3 centimeters of the esophagus into the abdominal cavity, you're going to have to do either a relaxing incision in the diaphragm to get it to close, or you're going to have to do what's called a Colles stapled gastroplasty, where you're going to actually staple a piece and take out a wedge of the fundus, so the gastroesophageal sphincter is lower, or the GE junction is lower into the abdomen. So a stapled Colles gastroplasty. So I've never had to do that. And then if they have to do a relaxing incision in the diaphragm, they will put a piece of mesh in there, and typically it will be biological or synthetic.
Hmm.
And they will typically use a synthetic mesh, a bioabsorbable mesh on the repair, something that's got an enteric coating so the bowel doesn't stick to it but will dissolve. Phasix is typically what I've seen used, cut in that C configuration. And yeah, that was some good. I'm glad I thought about that, because that's definitely an issue. You don't want any tension in that closure horizontally when you're bringing the crews together. But that's just like any hernia repairs. Tension free is the key, because if it's under tension, it's eventually going to fail. So in order to get that, you're going to have to either do a stapled Colles gastroplasty, or you're going to have to do a relaxing incision in the diaphragm. I've never had to do, granted, I haven't done a ton of them. I've done quite a few, but I've never seen the relaxing incision in the diaphragm. I've seen it, and I've never had to do a stapled Colles either. So, or Collis, however you pronounce that, Collis is how it's spelled. But yeah, that's typically the other things to be aware of. If they can't, for whatever reason, pull it down, and then there's a tip I can give you. Well, I'm sure the surgeon will know that, but robotically, there's something you can do that'll help aid your visualization. But that's it for the laparoscopic. I can think of anything else. Kelly, do you want to move on to
Okay, I don't
robotic?
know. Yeah, I will. And I don't know if we mentioned this is going to go for the robotic too, but I don't know if we mentioned, and I don't want to assume that people know this, but you're using a 30-degree typically scope, right? A
Mm-hmm.
30-degree scope. So
Yes.
for the robot, we're going to want a 30-degree scope as well.
Oh, yes.
For sure.
Mm-hmm.
Yeah. So, John, thanks for going through that so well. I really appreciate your detail in describing that. I could not have done as good of a job. We compliment we compliment each
You
other like
do a great
that.
job.
I will say
Don't
again,
brag
I'm
on
the
yourself.
beauty, he's the brains. That's just how this
I
department
wouldn't say
works over
that.
here. So
Not the brains. That's for sure.
I mean, I got
But
to be good at something, John. If it's looking
mm-hmm.
good, I can do that. No, I'm just joking. I try to have a little bit of brains about me, but no, you just really do a good job. That's a genuine compliment. You do a good job of going through the procedure in a structured way, and I really appreciate that. I know our
I
listener
tried
is
to.
going to.
I screwed that last part up, but yeah.
Well, that's okay. But yeah, no, our listeners, that's going to be beneficial. And again, I'll say and repeat that this is exactly the kind of podcast that you and I were looking for. Could neither one of us find when we decided to do this. So
That's
we can
true.
only hope to be bringing, again, relevant and important and easy to understand information to you. So
Yep.
for the robot, if we're going to bring the robot into this and have the robot assist us, there's just some considerations. I'm not going to go through the whole
Mhm.
procedure again because it's going to be the same procedure, right? We're just
Yeah.
using some extra tools.
I think it's a better way to do it because you have wristed instruments. I mean, there's
Absolutely.
so
The
many advantages the
visualization
robot has.
alone,
Yep.
I don't,
Well, the
you
steadiness of the
know,
camera doesn't depend on
it
somebody holding it.
alone, I
The surgeon can put it right where they want it.
know. So many. And I will say that work currently with a surgeon that will not move to the robotic platform on this surgery simply because, and I wanted to interject this when you were talking about
Oh,
the
okay.
endoclose, because he loves did I say that right? The endoclose, the state when
Endo
he's
stitch?
endo stitch. Sorry. Yes. Thank you. The endo stitch. I knew I wasn't right. The endo stitch, because it's so much quicker than
Mhm.
he feels like it's a lot quicker than him tying every,
Oh, yeah.
suture and cutting with the robotic and cutting the stitch with the robotic approach, because there's no
Yes.
robotic translation for the
Right, they
endo
don't have a
stitch.
they don't have a robotic
So
instrument for that yet, yep.
he literally does. He's an excellent
He's an
laparoscopic
excellent
surgeon.
he's a
Yeah,
robotic surgeon, he's excellent,
he's
and as a laparoscopic surgeon,
right.
he's
And John knows
excellent.
because John did come into
Yeah.
a
You can tell him he
travel
can
assignment.
undock the robot and use the endo stitch for that part
Mhm.
and then hook it back up
That's
again. I mean,
true. He'd have to scrub back in and all that, so that would still be time consuming. So I don't know how much
yeah.
that would defeat, but he literally, that's the one thing he's hanging on to from and you've got to appreciate that. He loves it, and it is a endo stitch. Listen, if you've ever moved from even on
Mhm.
endo stitch is wonderful. It's a wonderful
Yeah.
invention. I'm just going to leave it at that. It's a
Yep.
great thing
Works for a lot
when
of
they
different
know how to
things.
use
Yep.
it, when we know how to load it, and they know how to use it correctly. So that's
But that's the
great.
mark of a good surgeon. He does what's
Hmm.
best and what's quickest. The robot
And
is
what he's
better, but it does take
hmm
longer with those stitches. It
with
does.
certain things, and he just
Yep.
won't. And he's again there, and he's excellent at it. And he knows when he has a good team, he's going to get it done, get in there and get
Mhm.
it done. So that's great.
Yep.
So for the robot approach, we are going to want to consider what side of the patient the robot is going to come in on.
Mhm.
Typically, we want it coming from the patient's left, and the reason for that is
Mhm.
because a lot of times we are putting the right upper quadrant in way up there laterally for the liver retractor, and
Mhm.
also down right lower quadrant a little bit lateral is going to be the air seal assist port. So
Mhm.
that's going to be the 8 air seal there, and that's going to serve as the assist port. So if that's on the patient's right, you want the robot coming in from the left. So then you have room as the assistant to work. Again, this is going to be facility specific. It's going to be surgeon specific. So I want to add that, but I'm just going to talk about in general. Typically, the trocar placement for these is going to be across supraumbilical midline is going to be, I would say, close to midline supraumbilical is going to be arm 2. Um, if you're looking at the patient's abdomen, to the left of that is going to be arm 1. So
Mhm.
going left to right as you're looking, I'm not talking about the patient's
Mhm.
left or right. I'm talking about as you're looking at the patient's abdomen
Mhm.
from left to right, just right of midline, you're going to have I'm sorry, now here I'm confused. Just left of midline as you're looking at it, you're going to
Mhm.
have arm 1, supraumbilical median, supraumbilical, midline, you're going to have arm 2, and then 3 and 4 going to your right, the patient's left. So,
Mhm.
you're going to be lined up there. Again, right lower quadrant is a patient's right lower quadrant is going to be the air seal most likely, and then upper is going to be the small port for the liver retractor. I would just
Mhm.
have just a 5. Typically, the 5 millimeter laparoscopic trocar is going to handle that if you're using the Nathanson, the liver retractor that's got to be attached to the bed, in which case that arm can be left out, even in the
Mhm.
robot. And again, that's on the patient's right. The robot's coming in from the patient's left.
Mhm.
We don't have to worry about any interference there. That left arm is going to be tucked, same positioning with the footboard on the bed, the pink pad, chest strap, all that. They're going to be
Mhm.
secured to the bed as per usual. Now, depending on your robot arms, again, we all know this is surgeon specific. Cartier is very common to use in these, the grasper, a vessel sealer for sure. A lot of surgeons want a second Cartier. You could also use a tip up. They might want a tip up or a fenestrated bipolar, even if they're just using that to grasp. They don't want any energy on it. They may or may not want a monopolar scissor as well. So again, that is so surgeon specific.
Mm.
For this example, I'm just going to go with a Cartier, a tip up, the camera. The camera will be in the midline. In that arm 2 is where the camera is going to be. And you also want to consider with the robot how your elbows need to be dropped, in what order. If you're looking straight on at the patient, your arm 1 and 2 are on your left. So if I'm standing at the patient's feet and I'm looking up at the patient, arms 1 and 2 are going to be on my left. Those you kind of want to leave, you want to drop maybe arm 1 by half. You don't want to drop the camera arm. You'd want to leave alone, leave it straight up and down. Don't touch it. Now, where the vessel sealer and your other grasper are in 3 and 4, you might want to consider dropping those elbows all the way down. Just gives them more movement over there, and those are the ones that are going to be really moving a lot. Again, this is just something you have to gain experience with, and I'm still working with it, knowing how to anticipate how those robot arms are going to move during the procedure, if they're going to have any conflict or collisions with each other. That's always with any robotic procedure, something that you're considering. So just something to know there and to note about that setup. So you definitely have your air seal. Obviously, that's going to be an additional supply that you need for the robotic approach. You're going to need the air seal. You're going to use that air seal tubing. Make sure, again, you have your esophageal dilators in the room, the liver retractor of choice. The endoscopic tower is going to need to be in the room. And sometimes, depending on your facility or depending on your surgeon, sometimes the surgeon wants to do a preoperative scope and go down first. So that endo tower will need to be in the room and set up before the case gets started. So that's going to be part of your setup. Sometimes they don't want to do one until the end of the case. And so in that case, you'll just notify endo, or again, whatever your policy is on that, just know that you're going to need the endoscope tower in there and supplies in there. I'm so thankful at my facility. We do have an endo tech come in and handle all that. And they get everything set up for the surgeons for that look. Most cases, we don't do it until after the procedure. After we're done with the procedure, then he does the endoscope or the EGD. Again, my supplies I'm needing, I'm going to look and make sure I've got the Plurivac drains in the room. The Penrose is going to be in addition. The robotic suction you want to have available, and kind of know also, does he want you to have the laparoscopic suction, or can you just use the robotic suction to suction anything or kind of move anything, use it even to retract as they need you to. That is something that you can use that suction for. Hopefully, we're not going to need a lot of suction, but obviously you want to have it if you need it. Yeah, prepare to have the specimen removed. So you want to make sure, just maybe circle back with your circulators, make sure they have specimen containers in the room. I'm going to make sure I've got the padded graspers, the applied ones. You need the handle separate. We've just started using a disposable padded grasper that works really great and is no more expensive than using the handle with the other ones. So we have a full disposable padded grasper that's got the handle. It's just one piece. So depending on what your facility has there, I am definitely going to make sure I've got those bonds in the room and the 2.0 V-lock. 2.0 V-lock is typically what they use on the crura. So again, y'all, that's going to be surgeon specific. Make sure you know what suture they want for the closure of the crura, and then the ethibond as well. And I'm going to consider, do I want clips in the room? Do I want to have a robotic clip applier on hold? And in that case, then we need obviously the Hema clips to go with it. I'm probably, going to make sure I've got that in the room ready to go, as well as a laparoscopic clip applier, just in case he wants me to come in as the assist and be ready to clip something that might need it. Typically, you're not going to need it. He's going to have the vessel sealer, and that vessel sealer takes care of so many challenges with bleeding vessels or anything that they get into that they don't mean to, or something that's bleeding extra. The vessel sealer is an excellent tool to take care of that hemostasis. So typically you're not, but I just don't want to be unprepared. And as soon as I think, oh no, we're not going to need that, we might need it. So we will need it if I think that and don't have it ready. So I'm just going to be thinking of those considerations and have those things kind of on standby, ready to go for that robotic case. Other than that, I'm going to sit on the patient's right where the robot is not and just be ready to assist him or her however they need me to during that case. And it's really nice having that assist port to be able to get in there and retract. I'm automatically going to reach for my padded
Mhm.
grasper and have that at the front of the case because a lot of times we're grabbing mesentery or stomach or holding, retracting something back down for them. Even in a robot case where they have plenty of arms, there's a lot of times we just need to kind of provide exposure for them as they work here. Is there anything else that you can think from a robotic standpoint, John, that I may have missed about that?
For your assistant port, what size assistant port do you use?
I would say an 8, and when I was writing these notes, I was thinking about that. I was trying to think if
Hmm.
there's any way we might need. I guess if the hernia sac was really big, you would wish you had a 12 in so you could stick the big bag down. Um, but I think typically an 8 is adequate for that air seal assist port.
Yeah, if you're using the air seal, an 8 is good. If you're using a regular kind of insufflator, like
Mm,
whatever
mm,
strike or whatever,
mhm.
you're going to need a 12. I think it'll
Okay,
just
that makes
facilitate
sense.
putting. If it uses mesh, it'll make the mesh going in easier. It'll make your sutures to go in easier. Make the sac come out easier. And yeah, that assistant port. Now it
That's a
depends
good point.
on,
Yeah.
like you mentioned, facility and surgeon preference, whether they want to dock from the right or the left. I've done them where we've ducked on the patient's right,
Mm,
or it's been on the left lower quadrant, and
correct.
no matter the best way to do it, and a lot of times docs are like, well, you can put your assistant port wherever you want. So triangulate it between, if they're coming in from the left, between your 3 and 4 arms, just triangulate it in the left lower quadrant. And
Mhm.
opposite, if they're coming in from the patient's left side, then just your 1 and 2 ports just triangulated down in the right
Agreed.
lower quadrant. So you have
Uh,
enough room where you can articulate. And I would say a good caveat is when they're making their initial port incision for the camera, they want to be about 15 centimeters from the xiphoid.
okay. Yeah.
Air a little higher, because then you can look down into the chest rather than trying to look over the stomach up into the chest.
Correct.
So,
That's an important point from the surgeon's
mhm,
perspective, John. Thanks for mentioning that. It really
mhm,
is because it's going to make a big difference where that camera is and how close to the xiphoid is or far away from the
mhm,
xiphoid it is. So that's an excellent point because yeah, that stomach can really get up in the way. And speaking of the stomach, they are going to have an NG tube most of the time. Anesthesia is going to have an NG tube
initially to
in
start with,
to
yeah, and then they'll
start,
switch it out and put
and they'll switch it out.
the bougie down, or they could, I
Mm-hmm.
guess, use a Visi-G that you would use for a gastric bypass, but I
True.
haven't seen
Yeah.
that used, and then it would accomplish both. But that's typically it. Now I know that there is a harmonic attachment for the robot, but I've never seen it. I've seen it in videos because I've
I
looked at a
haven't
lot of
either.
videos on that. I've never used it. A lot of docs will just use the vessel sealer for that,
Mm-hmm.
and the new vessel sealer extends even better because they can suture with that too if
Yeah.
they need to. So
Yeah.
I've seen docs do
That's
that, so
that's
that's
right. I
cool.
can't speak to the DD5 and
Hmm.
what some I know
It's
there's
nice.
some different caveats, different things
Hmm.
that are available with the DD5 that aren't. I don't
Pretty
have any
cool.
experience on that front. But right. So, yeah, that's a good point, and I was gonna bring that up too about the assist port. If the robot can't come in from the patient's left. I mean, obviously there's
Hmm.
workarounds with that, and you just go with it. The important thing is for the first, it's very important for you, the first assistant, to know, to be thinking about those things,
Hmm.
those aspects of the case, of the robotic case. Where is the robot going to be? Where are the trocars going to be placed? What angle do they need to be at? What are the potential or most common problems or that you're going to encounter with arms hitting each other and whatnot? Um, those are all things to be looking at, and yeah, you're going to have to pass the as in this robotic, you're going to pass the pin rows in, you're going to be
Hmm.
passing things back and forth to get in the, just like in the laparoscopic case too, you
Hmm.
might be retrieving needles, and you will in the robot case, you definitely will be retrieving needles in and
Hmm.
out. So again, that anatomy comes in handy to know, and
It
not,
does.
not
It
just
does.
handy,
Yep.
necessary. You've got to know where your anatomical structures are, and the surgeon will
Hmm.
remind you if there's something glaring, I'm sure. But you need to know, you need to be cognizant of what you're passing your
Hmm.
instrument over and what you're pulling needles out over, and just very special considerations
But
for.
I've got a question for you, Kelly,
Okay,
because
ooh.
we've talked about the Laparaflex or Diamond Flex, and we talked about the Nathanson. But what other ways have you seen surgeons suspend the liver so it's out of their way?
So yeah, the one cool way is with that suture hammock that some surgeons will just be really savvy and string a suture up, kind of loop a suture, as whether it's a silk or a proline, and kind of put it through the skin. You loop it around the liver, where the liver is hammocked up now in a piece of suture, and it comes up through, and it kind of just stays there the whole time. You don't need an extra instrument. You don't need an extra port to do that.
Okay.
The other way I've seen them retract the liver for other cases, and you brought
Hmm.
up a good point with this, would be to bring in from the patient's left. That long grasper will lift up the liver, and then you grasp the patient on their right. You grasp the peritoneal wall over there, the peritoneum, and then the grasper just hangs there.
Mm.
And it can be, depending on the patient's anatomy, it will likely be in the way. That method of retracting the liver will likely be in the way for this procedure, because it's obviously coming across exactly where the surgeon needs to be working.
Mm.
But the fan retractor is handheld, right? I mean, so you have to
Hmm.
be holding that the whole time. So that's not really a viable situation. But the suture hammock, and again, if you're not familiar with what I'm talking about, there are lots of examples on YouTube. We
Hmm.
see on some of our surgical colleagues, surgeons that post videos on YouTube of their surgeries will
Hmm.
do that and show you how it's done. That's a really cool improvisation that a surgeon somewhere came up with, and then word spread about it. So
Yep. Yep. I've seen that done before. Let's see what else. I don't think there's anything we missed or things we want to go over, because there's, I mean, there's myriad of different ways. We talked about
mhm.
we talked about the stuff we would need, the equipment we would need. We went over the bougie, the different types of mesh, Penrose drain, and then how they clamp that Penrose drain. They could use a hemalock. You could even use an endo loop. I've seen surgeons do that where
Right.
they
I've
pass it through
seen.
that. But basically, the procedure is pretty simple. The 6 steps, you just need to know each one and the variations and what you want to be aware of. But you're going to have the hernia reduction, a high mediastinal dissection, excision of the
Mhm.
redundant sac, and then you want to address the tension and length. Make sure it's 3 centimeters into the abdomen, and then it's not too tight, your closure. There's no tension. Curl reconstruction then, and then your anti-reflux fundoplication. Attendant stuff you'll need for that. So typically, yeah, whether your surgeon does it laparoscopic or robotically will dictate a good part of that as well. You won't use the endo stitch like you mentioned if you're doing it robotically. So,
Mhm.
and we've mentioned this before, and we've in the other hernia video, I linked Dr. David Lourier's a couple of his videos, masterclass on
Yes.
inguinal hernia, robotic inguinal hernia. He also has a good one on hiatal hernia repair, and some good narration in there as well. And he points out a lot of different, things that help with that import configuration,
How do
things like
you,
that. So,
for our listener, how do you spell his name so they can find him?
oh, you were
Find
going to
that.
ask me that.
I know.
It's
I don't know either.
I think it's Lourie, David Lourier. He's at UC San Diego, I believe.
Okay.
But hang on, I'll get it for you. I'll look it
Yeah,
up.
pull
Oh,
that up.
actually,
That is
I did.
that's a really good
Go ahead.
resource. That's just a really good resource. I
Yeah.
mean, and I was going to encourage our listener too, again, to utilize YouTube and utilize
Hmm.
whatever resource, especially with technology resources that you have. I Behind the Knife is one of John and I. We love
Oh
that
yeah.
podcast, Behind the Knife, and it's toward surgical residents. But we glean a lot of good information just from the surgeon's standpoint. They're learning to be surgeons, but as the first assistant, we always want to know from their
Sure.
standpoint if we can know what they need to know, why they need to know it, why they're doing what they're doing. It's just going to make you a better assistant. So listening
Sure.
to those kind of podcasts is going to enhance our knowledge and I believe help us be better first assistants. So Behind the Knife is
I
another good
agree.
one. And
I agree. The spelling of his name is, yeah, Lourie.
okay,
Dr. David Lourier. I
okay,
did email him and ask him to come on the podcast, but he said that
okay.
he's just way too busy.
Busy.
But he will keep it in mind. Let's see. My schedule is swamped over the next year. Thanks for the offer of coming on your
Oh,
podcast, but I'll have to decline for now. So,
appreciate
but
your ambition, John. That was awesome to
well, I
reach out. Yeah,
emailed to make sure it was okay to link his video. I mean, it's a link. It's not.
oh,
I'm not. And I gave
right,
him full attribution, but I just wanted to make sure it was okay. Plus, I wanted to use it as a door to get in and see if I could get him on the podcast. But
right.
I'll keep asking him over
Yeah,
time, and hopefully, we'll get him on. But he's
yeah.
got a great video on a robotic hiatal hernia repair. And I think he's
Great.
an
That's a
excellent
good tip.
surgeon. So,
So we're gonna
yeah.
leave. Yeah, we're gonna
Yep.
leave you with that then. So yeah, go check that out. I'm gonna check it out for sure.
Yep.
Um, And we appreciate you listening. We just hope that you get something from these podcasts. Keep giving
Yes.
us, and we've received enough, and we're not sponsored by anyone. We just
Nope.
do this in our own time. We enjoy
Hmm.
doing it. Again, we both wished that we had something like this. We both enjoy listening to podcasts. We both
Hmm.
drive a lot. I'm in the car a lot, traveling here and there, and I love to listen to podcasts, especially educational ones here and there. And there was nothing for first
Hmm.
assistance. So again, that's why we created this podcast. We are encouraged to keep doing it. We've gotten really good positive feedback from a lot of people, and we want to keep bringing you relevant material. So we're going to strive to do that, and we always welcome comments and suggestions. If you like and subscribe, we're on YouTube. If you're listening to this on Spotify or Apple Podcasts, wherever you listen to your podcast, this is in video form too. I mean, it's very boring. We're just sitting here talking. There's nothing great to look at. John does try to
Could be
link
pictures.
visuals. Yeah. Well, you try to link visuals. Yeah, exactly.
Hmm.
He does do a good job of that. Like bring up, and he can put in, when he's editing, he can put in pictures and that kind of thing. So that's helpful to, if you're a visual person, to see that. But yeah, so we're on YouTube if you want to look us up there and follow our channel there. But yeah, when you like and subscribe, as you well know how social media works, then it just helps the algorithm so that when people are
Yes.
searching for something about surgical first assisting, they're going to see this, and it just gets the information out there. And we've got a lot of good influencers, as they call them.
Hmm.
There's a lot of good people coming forward on Instagram and
Hmm.
Facebook, and kind of I'm really great for our profession because
It
it's
is. I
so
think so.
it's just not a known about profession. And so I think
Hmm.
it's great.
Yep.
And we're just going to keep plugging along. And again, I've
Yep.
said here recently that we did slow down this year. We kind of started off with a lot of ambition and churned out a lot of podcast episodes last year. And then we started to slow down. We still have some in I think you're going to drop, as we're recording this, you're going to
Hmm.
drop our second hernia episode. And then this
Yep.
is our third
This one will
hernia
follow. This one
episode.
will follow right on the heels of it because I have more time to do some editing now.
Yeah.
And
So if you notice, if you're looking at our lineup and you've noticed a gap in the dates, it's just because life,
John's
happened
lazy.
and been busy. And no, not lazy at all. We've been busy
No,
and
some stuff has gotten in the
distracted.
way. Yeah.
Yeah.
But
But we're not stopping. I mean,
no.
so just they might be trickling out a little bit slower right now, but we've
Hmm.
got them there. Believe me, we are recording. They are there in the holding tank, and we're going to be getting them out. So keep on listening, do some repeat
Hmm.
episodes if you need to, and keep doing a great job at first assisting. And if you're just getting into this
Hmm.
profession, we want to encourage you just to listen to those episodes about resources and starting
There's so
out.
many
And
more resources out there
mhm,
now than when you and I
yeah.
both first started.
Hmm.
It's wonderful. And this is our second season.
Hmm.
So that's a friend of mine who has a podcast for a different profession told me that 97% of podcasts do not make it a year, and we've been doing it over a year. I mean, we have,
Hmm.
I don't know, 27
And our
episodes or something
listenership
like
has
that.
grown. We've
It
grown. I
has.
mean,
It has definitely.
we've
We're
had
grateful
growth.
for everybody. Yeah.
Yeah.
That,
And again,
this is
it doesn't benefit us at all, except to know that we're doing somebody some good, that people are listening and they're benefiting from the information that we're putting out. We don't get
yeah.
paid. We're not
Nope.
sponsored by anybody, blah, blah, blah.
I mean, I
So,
created it for me, really. What I wanted to see, if I
mhm,
was a new first assistant or if I was a first assistant, what I wanted to find out there. Now it's still a
that's
work in
right.
progress. We're
Mhm.
getting there, but if you are getting something out of it, if you want to do us a kindness and go to Apple Podcasts or Apple and leave us a comment, that'll help get the algorithm to
Or
push us
review.
out to more people.
Mhm,
But yeah,
mhm.
if you just give us a review, it would be wonderful.
Any kind of interaction like that
Yep.
would be
And if
great.
there's something you want us to cover, by all means do that. And I'm working to try. Kelly and I've been talked about it, and we mentioned it in an earlier podcast, but we're trying to expand and get more things. I'd like to get more reps on with new products as they come out, or
Mhm.
maybe even just before they launch, that we can let you guys know about it.
And we've got
So
some exciting things coming up on
yeah,
that front. We've
I think
got some
so.
reps lined
Yeah,
up. We've
I
got
think
some
so.
really exciting things that we can kind of be on the cutting edge a little bit of letting you know
Hmm.
about.
Yeah.
So you stay tuned, because we're in our little corners of the world, wherever we are. We've got a little bit of good information coming out about products, devices, that kind of thing. So
Yeah.
yeah,
If
and we've got
there's,
some good reps lined up to come on as
yep.
well. So yeah, we're excited. We're keeping
Oh
on
yeah.
going, and we want you to keep listening and spreading the word. So
But yeah, like I said, if there's something you want us to cover, shoot us an email at the
mhm.
surgicalassistantpodcast.com, or you can leave a comment on there. And Kelly's usually good about returning the comments on there. I don't get the notifications when they're on there, but when I log on to upload an episode, then I usually see if there's a response on there or a question, and I'll try to answer it, or I'll shoot it over to Kelly for her to answer. But we are grateful for every one of you, all 12 of you. We're really grateful. No, I'm just kidding. I'm sure there's a lot more, but no, it's wonderful. I just like hearing good things about it. People I've run into have said they've gotten a lot of it, and that means a lot because,
Mhm.
like I said, it's a work in progress. Hopefully, we'll just continue to get better.
Yeah,
I'd like to learn how
that's
to add
good.
video into the podcast,
Mhm.
so I could do a short video excerpt of something, but that'll come in the future. I'll learn
Mhm.
that.
Yeah.
So I might be switching platforms, but that's not going to affect this podcast at all. But it's just how I edit it. But yeah, so
All
yeah,
right.
be wonderful. You guys have a great weekend.
All
Hope you
right.
had a
Yep.
great 4th. Did you have a great 4th, Kelly?
I did. I did. We had a good 4th of July. So yeah, we're in
All
middle.
fingers and toes it's still attached.
Yep, we're right here in mid-July recording this, so, yep,
Mm-hmm.
just dealing with the heat right now. So, yeah, so you guys take care
Mm-hmm.
and look for where this completed our hernia series. Next, we're gonna be really working on a mesh episode. We're gonna learn
Mm-hmm.
everything about mesh that we need to know and how all the ins and outs about mesh. So it's gonna be really educational, and we're gonna learn a lot doing
Yep.
that as well.
Yeah, we got
All
a couple
right.
of more hernia ones coming up, so I think it'll
Mhm.
be really interesting. But hope you got something out of this, you guys. Thank you very much.
All right, see you
Have a
next
good
time.
evening. Take care.
Thanks for listening today. We invite you to like and subscribe to this channel and leave a comment if you'd like. Feel free to look us up on Facebook at the Surgical Assistant Podcast or email us at thesurgicalassistantpodcast@gmail.com. Until next time. Content of this podcast is in no way intended for diagnosing or treating surgical conditions. No patient-specific information is shared. All HIPAA guidelines will be adhered to.